My name is Pim vanOoij and I would like to present to you my work on detection of regurgitated flow using 3D averaging of normal heart for the flow MRI. So regurgitation is abnormal backflow over the heart valves and may lead to heart failure and can occur over any of the four valves. So echocardiography may miss eccentric flow jets, and MRI is the current gold standard by, for example, for mitral regurgitation, subtracting the aortic flow measured by 2D flow MRI from the left ventricular stroke volume as calculated by standard CNAs. But this is an indirect calculation. And for this reason, direct quantification techniques were developed for 4D flow MRI. We found that in severe cases, tracking of the flow jet rather than the valve resulted in better correspondence with the indirect method. Flow tracking involves manual work and does not account for multiple jets if they're present. Furthermore, valve and flow tracking are measurements in one plane, but regurgitation should be a 4D volume of flow with abnormal velocity, magnitude, and direction. So the research question is whether we can design a method for fully automated detection, visualization, and quantification of regurgitated flow in 4D using 4D flow MRI. So I've been working for a good deal of my career on cohort averaging of volumetric data using registration and interpolation techniques for the detection of abnormal velocity magnitude. And I recently extended this framework for the detection of abnormal velocity direction as well. So will this work for whole heart 4D flow MRI as well? And since whole heart is way more complex than aorta only, I foresee that this is not going to work yet without limitations. So my hypothesis is more or less. We performed 4D flow MRI in 10 patients with congenital heart disease and 17 healthy volunteers using our recently developed framework allowing prospective undersampling in multiple dimensions, which we call PROUD. We used camera-based respiratory gating with the vital eye, as shown here, and reconstructed the data with compress sensing algorithms. The spatial resolution was 2.8 by 2.8 by 3, and 30 time frames were reconstructed. We did not use any contrast agent. The reconstruction contained background phase offset correction by subtracting a static tissue plane from the velocity data, and velocity aliasing was corrected using a Laplacian algorithm as developed by Leuker et al. The patient data was filtered with a 3 by 3 by 3 median filter, but not the controls, and the phase contrast MR angiogram was created by multiplying the phase contrast magnitude images with the squared velocities, this time leaving out the square root. A custom-made noise filtering algorithm was applied based on sign changes and velocity changes over time, higher than 0.25 times the VENC. The time-averaged phase contrast angiograms were manually segmented in mimics. In order to create 3D averaged maps of the healthy volunteers, we first calculated the spatially averaged velocity magnitude in the segmentation for each time frame and used cross-correlation of the curves to temporally align the data for all volunteers. The segmentations were subsequently registered to one arbitrarily chosen segmentation, followed by interpolation and averaging of the velocity magnitude and vectors. For the detection of abnormal flow in the patients, the patient geometry was registered to the volunteer segmentation that contains the average, and volume rendering was performed of the voxels that had a higher velocity magnitude than 2 times the upper threshold of the 95% confidence interval of the volunteers, and that deviated more than 90 degrees from the volunteer averaged velocity direction. So abnormal flow was then quantified by multiplying the number of voxels with abnormal flow with the voxel volume. And we correlated this abnormal flow volume with previously quantified regurgitated flow using flow tracking for the time frames where with regurgitated flow only. And for all patients, we correlated the time averaged abnormal flow volume with the time averaged regurgitated flow volume. All methodology and statistics were performed in MATLAB, flow tracking in CAS from P Medical, and visualization in GTFlow. So here we see volunteer 2 on the right, and we registered volunteer 2 to volunteer 1, and the time frames of volunteer 2 were shifted by one time point where cross-correlation showed a slightly better correspondence. The velocity magnitude and vectors of volunteer 2 were subsequently interpolated to the segmentation of volunteer 1. And then you can take an average. which we see here. Here, the volunteer average velocity is shown, and we shifted the volunteer average velocity one time point to match the curve of this patient with tricuspid regurgitation. The patient geometry is subsequently registered to the volunteer average, and the volunteer average velocity magnitude and vectors is interpolated to the patient geometry. So volume rendering and quantification of the voxels where the velocity magnitude was higher than 2 times the upper boundary of the 95% confidence interval of the volunteers, and where the velocity deviated more than 90 degrees from the volunteer average, can now be performed. So here we look at a time series of tricuspid regurgitation and found that there was no correlation between flow tracking and abnormal flow, for the reason that the novel method picks up abnormal flow in other locations as well. For this time series of pulmonary regurgitation, we did find a good correlation between flow tracking and abnormal flow quantification. Here is an example of abnormal aortic flow, and we found a good correlation with flow tracking. However, it seems that abnormal flow in the ascending and descending aorta rather than the regurgitated flow is detected here. The last example shows mitral regurgitation, which did not correlate with flow tracking since the algorithm picks up abnormal flow in other locations as well, mainly in the left ventricle. For all patients, there was a significant correlation between the time averaged flow tracking and abnormal flow volumes. So the proposed methodology has potential for automatic detection, visualization, and quantification of abnormal flow, and provides simple visualization and quantification of complex flow that could be relevant in this clinical setting. The method is fully automatic, but limitations were already shown in red. Proper age matching should be pursued for an optimal result. Ideally, no filter would be applied to the patient data. I discarded the square root in the PCM array calculation to get better contrast between blood pool and surrounding tissue, and we really need to come up with better methodology for segmentation of the cardiac chambers, preferably fully automatic, which could maybe be achieved with machine learning in the near future. I now use the spatially averaged velocity magnitude and cross-correlation methodology to align temporal curves, but a better definition of cardiac phase distribution can be thought of, and of course arbitrarily chosen segmentations and thresholds are not ideal and need validation. So there is much more work to do to optimize this technology. And with that, I'd like to thank my collaborators and the audience for listening.